Well, good morning, everybody. I'd like to say hello. I'm Jeannie Marazzo, the acting head of the Division of Allergies and Infectious Diseases, and I'm really delighted this morning to introduce the Kirby speaker for our Grand Rounds. Many of you probably knew Dr. Kirby, who was a wonderful mentor and physician and scientist, passed away several years ago, and his family generously created a fund to bring a speaker of a national stature back for Grand Rounds and also to have time with the infectious disease division, and that's been a really successful endeavor. So this year, you're in for a treat. We have Dr. Gail Bolan, who's a long-term friend and colleague of mine. Gail comes to us from the Centers for Disease Control and Prevention, where she's the director in the Division of STD Prevention. Gail trained at Dartmouth initially in medical school and then completed residency at University of Virginia in Charlottesville and then trained in infectious diseases at Tufts and Stanford. She then did an EIS officership at the CDC in Respiratory and Special Pathogens branch, and then she came back to the West Coast where she led the San Francisco City STD Clinic really right as the HIV era was getting underway in a big way. So it was right there at the front side of the intersection there of STDs and HIV. She then rose to become the leader of STD services for the state of California. And I should say, when she was at City Clinic, she came very close to persuading me to do my fellowship in San Francisco, and I was only dissuaded by the very persuasive Dr. King Holmes to come here to the University of Washington. And it all worked out well because I've gotten to work very closely with Gail over the subsequent years. She has many other accolades, which I will not go into, but I'll just say that she's really been an incredible resource for the field, and also in terms of mentoring people who are interested in implementation or program science, really an important, I would say, luminary. So, Gail, with that, we're interested to hear you talk about sexual health.
So thank you very much, and it's really been a privilege to be here, especially in honor of Dr. Kirby. I actually started my ID lab research at Stanford with Gary Skulnick and was looking at an iron-regulated protein for Neisseria gonorrhea. And I quickly realized this organism is way too smart for me, and I got to go back and work with people. So that's sort of how I left the bench field and went into public health. And you're going to hear some of the concerns we have now about the threat of untreatable gonorrhea, and it's hard to believe as an ID-trained doctor we could actually live in an era when we don't have antibiotics to actually treat common problems. So I'm going to talk a little bit in a more holistic sense around sexual health, and we do have some controversies and we have some challenges. So first, I'd just like to give a little bit of an overview of what some of us are saying sexual health is. And this is something that we have a certain role in sexual health activities in the federal government, but we also get all of our money from Congress. And Congress is not interested in funding pleasurable sex and things like that, so we have a very disease-focused activity. But I'm hoping that the medical institutions of the United States will start looking at sexual health like we look at physical health. I think we spend, 90% of our time training our medical students in the world of physical health, maybe 5% in mental health, a couple percentages in social health, and I don't know, where are those departments of sexual health? So I think we've got to start having this dialogue if we're really going to have an impact on the diseases that I'm going to talk about. And clearly from a disease perspective, I think our sexual health work is being threatened by untreatable gonorrhea. We certainly have done a very anemic job of scaling up what I consider one of the advances of the century, our HPV vaccine. And now we have more concerning trends of divergent issues of STD rates compared to HIV among men who have sex with men. And certainly healthcare providers play a very critical, important role in STD control. If you don't know, our main strategy is appropriate diagnosis and treatment. And we have many providers in this country who are still not following sort of basic STD guidelines in terms of screening recommendations and standard recommended treatment. So we do have a definition of sexual health that comes from the WHO, which is a state of physical, emotional, mental, and social well-being related to sexuality, not merely absence of disease or dysfunction or infirmity. And it requires a positive and respectful approach to sexual relationships, as well as possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. And for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And we're having quite a debate about this sort of on the national level, and we've got some we've got, people on the right and the left, but we've also got a lot of people that say this term doesn't resonate for me. When people are having sex, they're not thinking about health. So I'm still wondering if we can have someone come up with a better term for us. Some people said maybe we should use personal health, but at the moment, sexual health is what most are using. So again, we'd like to use this approach in a more holistic way to move away from our disease-focused, sick care approach to more of a healthy approach, and we hope it will be able to reduce stigma. And we think it is relevant for everyone because sex actually is something that most people do at some point in their life. It's not like smoking where we say, no, just don't do that. We really need to be preparing our children to have healthy sexual lives and start at a very early age. So when they choose to be sexually active, they're doing it in the most healthy, positive way possible. So again, I'm a great believer we have to normalize our conversations. I started early with my kids when they were about 5. My daughter did write her college essay about our family dinner conversations, about my mom's always running around talking about condoms and penises. But the point was that it's just a body part, is that she wanted to go to a place where there was open dialogue and discussion and diverse opinions, that people could have frank conversations and discuss these issues. So with that introduction, now I'm going to talk about the problems we have. So for those of you who know much about Neisseria gonorrhea, it has really demonstrated significantly the ability to progressively develop antimicrobial resistance since antibiotics became available. We started using sulfonamides in the 40s. They didn't last very long. Penicillins had a good ride from 1945 until we actually dropped the recommendation to treat gonorrhea with penicillin in 1989 when we had significant problems with PPNG in this country. Tetracyclines were sort of a backup. Fluoroquinolones also didn't last very long, and now we're sort of at the end. We have one class of antibiotics to treat syphilis, and because of recent trends, which I'll discuss, we're concerned about using the oral forms of cephalosporins, which makes it very challenging in the private sector because most physicians in the private sector don't have injectable medications at the time the patient comes in with the symptoms or the contact comes in and they need to be treated that day. So we in public health actually now have some of our field investigators driving medications around so that people can get appropriately treated, which is not a very efficient way to be managing our public health and clinical problems. So we at CDC, and actually credit to people back in 1987, and John Zentelman actually recognized when we were no longer going to be testing for PPNG because we weren't using penicillin, we didn't have a lot of labs that were doing MICs on non-sterile isolates. And so CDC set up the first antimicrobial resistance surveillance system. Most of our public health surveillance is not paid for. We collect information that we get out of clinical labs. And we recognized we were not going to be able to monitor antimicrobial susceptibility for Neisseria gonorrhea because no one was going to be testing for it. So we have these sentinel sites, these little blue clinics around the country that are generous enough to collect specimens from symptomatic men that come in. We think that it gives us a population-based sample of both men and women and MSM that come into these clinics. And they originally, everyone was doing culture, so they were doing the culture and then sending it to labs, and we would send them to referral labs, regional labs for MIC testing. Now we've been challenged because most people are using the nucleic acid amplification test, the molecular test, which we don't have the markers yet for resistant mechanisms. And so now we've got to ask these clinics both to culture and to be doing their NAT testing so that we can maintain this system. So what we saw that was concerning was this significant increase in the proportion of isolates that had elevated MICs to cefixime. We don't actually have clear cutoffs for resistance, so we're seeing decreased susceptibility. As you notice, we have a little blank in the graph because when cefixime went off patent and it wasn't being made in this country, CDC on the cheap decided not to monitor the MICs for cefixime, so it would have been nice to know what was happening between 2007 and 2008. But at least we were very concerned when it came to 2011 that we were having a significant number of strains that had decreased susceptibility in this country. We also heard about worldwide reports of treatment failures in superbugs from Japan. And then we were starting to see a pattern that we saw when we had fluoroquinolone resistance. For whatever reason, it seemed to start in the West, and it seemed to start among men who had sex with men. So in the first half of 2011, we already were above our threshold. We had an arbitrary threshold that if more than 5% of strains were showing either resistance or decreased susceptibility, we moved to the next drug. Well, the problem was this is the first time we had no drugs to move to. So we had a big discussion about how should we respond to this threat. And we had a lot of discussions about should we increase the dose of cephalosporins. Certainly England is using 500 milligrams of ceftriaxone to treat gonorrhea. We've looked at the pharmacokinetics. And it was based on some modeling studies. We've not felt that that's going to be helpful. We also recognize, I think sometimes we're always looking at the half-empty part. We're not looking at the full glass. We also recognize that 68% of our isolates actually are susceptible to everything, penicillin, tetracycline. So if we could have a rapid test that we could get a susceptibility pattern on, at least for penicillins and fluoroquinolones, we could actually direct therapy, but we're not there yet. We thought maybe we could cycle antibiotics. There have been some research studies for gay men where, they had posters, at least in San Francisco, in January, and then that you knew that was your, day to go in and get something. But we thought we can't even get providers to scale up our treatment guidelines within a couple of years. So if we're going to be changing every month on which drugs to use, that didn't seem very feasible. So we actually went for the theoretical dual therapy. Let's use two drugs that have different mechanisms of action, and hopefully that will help mitigate the emergence of further resistance. We also did a treatment trial with NIH, and we chose available drugs that were FDA approved that we thought would work against Neisseria gonorrhea, and it was a multi-center randomized open trial, non-comparative, and we had approximately 200 patients that were randomized either to gentamicin, which has the disadvantage of being injectable again, and added 2 grams of azithromycin, or gemifloxacin, which is expensive, and azithromycin. The reason these were chosen in addition to being available was that which had been in vivo seen an additive effect between gentamicin and azithromycin. And we knew that gemifloxacin was more active against GC than the known Cipro resistance or those that had the mutations. Basically what the study showed, these two regimens were very effective for treating Neisseria gonorrhea at the urethral and cervical sites. We really didn't have enough sample to look at the extragenital sites, the rectal and pharyngeal, but at least of the few patients that had those sites of infection, there was 100% cure rate. The downside of the study is, unfortunately, there were significant GI side effects in both arms, to the point that about 3 or 4% actually had to discontinue the regimen because of vomiting within an hour after treatment, probably related a little bit to the azithromycin. So because of this, we felt that these regimens are probably good alternatives, but not good enough to be considered a recommended regimen in our treatment guidelines. So as a result, we first changed our guidelines in 2012 to say we want to use dual therapy. At that time, we were recommending ceftriaxone and either azithro or doxycycline. But what we've seen with the susceptibility patterns in our strains of GC in this country is the isolates that have decreased susceptibility to cefixime or cephalosporin also carries the penicillin resistance. And so we felt it didn't make a lot of sense to add the doxycycline. So in our revised guidelines, which everyone always asks me, when are they coming out? They were to be the 2014 guidelines. I'll talk about them a little bit later. But if you haven't heard, we have a little bit of Ebola work that we're doing at CDC, and our MMWR publications have a little bit of a backlog because Ebola publications are getting higher priority. So I was hoping when I came to give this talk, I was going to share with you our new guidelines. I'll give you some tidbits, but I think more likely they're going to be out in early 15. If you can't get ceftriaxone, or if a patient is allergic to ceftriaxone, or if you're giving expedited partner therapy, which is where you give extra medication, and most states now have laws, including Washington, where you can give extra medication to your patient if you think the partner is unlikely to get treated in a timely fashion. It's a harm reduction strategy. The goal is to get partners in for full evaluations and a complete HIV testing and STD screening. But if that's not going to happen, it is permissible by law to give extra medications to take home to patients. Obviously, giving an injectable to take home is not going to be feasible. So if you need to do expedited partner therapy, we do recommend cefixime and azithromycin. And if there's a cephalosporin allergy, because we have had some treatment failures with single monotherapy of azithro, to go ahead and use the gentamicin or gemifloxacin, but be conscious of the GI side effects. And just because we're a little bit concerned about the pharyngeal site, it's always been a hard site to eradicate Neisseria gonorrhea, we are recommending if an alternative regimen is used, you should get a pharyngeal culture. We don't really know how long things, or a NAT test, how long They persist. Studies are being done now. We think about 2 weeks, but sometimes people have some sex before they come back, so it gets difficult to sort out treatment failure versus reinfection. So I think it depends on your patient, but it's important to bring people back in because we're looking for possible treatment failures or even possible resistance at that site. If you haven't heard, I think partly because we were sounding the alarm about the threat of resistant gonorrhea at the same time that other people at CDC were concerned about the threat of other infections, especially in hospital care settings. CDC does have a report out now articulating the urgent threats in the United States, and actually gonorrhea is in the top 3, which has been helpful to get more attention and resources and interest in developing more drugs in the pipeline, getting better diagnostic tests, and we're also at some point hoping for a vaccine. And actually, our president actually has made an executive order to further antimicrobial stewardship and concerns, other concerns that we have about antimicrobial resistant threats in the United States. So the good news is this is a problem with success, because then all of a sudden no one wants to give you any more money, when you work in public health. Probably related to a clonal nature of strains that were circulating. This has been seen elsewhere in Europe. At least we've been able to mitigate sort of the decreased susceptibility of cefixime as well as ceftriaxone, and now are well down below the concerning threshold that we were seeing of 5% in MSM in the western part of the United States. And this decline has been seen in the West. It's been seen among MSM. So we're at least encouraged by this, although I've heard some reports our 14 data may not show us that this trend is continuing. So I want to make the point that we're still on the edge of the cliff with the last class of antibiotics available to treat Neisseria gonorrhea. We've always been concerned sort of about these extragenital sites. At the rectum, isolates may be less penicillin and erythro susceptible, possibly due to the MTR locus mutations that reduce outer membrane permeability to hydrophobic molecules that allow survival in the rectum. And we also know that at the rectal site that there's increased shedding of HIV. And then the throat has been another area of concern. There's been a hypothesis that these other commensals that have resistant genes, they're having sex in the throat, so they're exchanging DNA, and that's how we're developing these resistant strains of GC. But I am going to share with you some preliminary data that we just completed in something we called our EGG study, the extragenital gonococcal study, where we actually looked at MICs at all sites. We had 205 individuals at the pharyngeal site, 261 at the rectal site, and 976 at the urethral site. And with confidence intervals, we really did not find any significant differences at any sites. I know that NIH is going to be doing a larger study. So at least we had some preliminary data to say at the moment we're not seeing organisms with higher MICs in the pharynx or in the rectum. So that's the gonorrhea concern. Now we're going to talk about our unfortunately sad story of HPV vaccination scale up in this country. So first of all, I think we all had great expectations when this vaccine became available. There was a randomized clinical trial of quadrivalent vaccine in over 20,000 women. It had very high vaccine effectiveness for vaccine-type precancers in women without any evidence of HPV. It didn't have any efficacy, though, in those with pre-existing vaccine-type infection. There was also bridging studies that were done, immunogenicity studies that showed high and sustained vaccine-type antibodies in 11 to 15-year-olds, because it was a little bit challenging to do studies, given you didn't have an outcome that you could follow in a short period of time in that age group. So in 2006, the FDA approved, and then ACI recommended, and it's really important. ACI is the only advisory committee at CDC that actually, when you make a recommendation, money goes with it. 317 has to pay for these vaccines. So this was an important recommendation to use this vaccine in girls starting at the age of 11. You can go down to 9. I don't have time to go into all the details. It's also now recommended for boys. And for girls, you can do catch up to the age of 26. Boys in general up to the age of 21, but for men who have sex with men or who are immune compromised, including HIV, you should also go up to the age of 26. And actually, Harold Zuhausen was awarded the Nobel Prize for scientific linkage of HPV and cancer. So we thought this was really great. And when we first started looking at sort of vaccine coverage through our surveillance system, our teens national immunization surveillance system that's done in the Center for Immunization and Respiratory Diseases, looked pretty good, that we were sort of getting, for females, about 25% in 2007 were at least getting one dose, which was fairly comparable to the other adolescent vaccines, be it the meningeal conjugate vaccine or the Tdap vaccine. We've also seen some interesting success in terms of our monitoring system. So we actually have a national household survey, NHANES, where we've been monitoring prevalence of a variety of infections, including HPV. And if you compare the cycle from 2003 and 2006, which was pre-vaccination era, to the 2007-2010 cycle, you can see that there's been a 56% decline in the oncogenic types of HPV in the 14 to 19-year-old age group, and we don't really see it in the other age groups. So there's some suggestion here that even despite our anemic uptake of the vaccine, we're starting to see decreased prevalence of these vaccine types in younger women. We also look at market scan data, administrative data at CDC, and we've seen similar declines in sort of looking at rates of genital warts in females, and we're also looking at this in males as well. And you can see in the sort of purple bar, here I think I have a pointer, that we've seen a significant decrease since 2006 in genital warts, which we think is also related to our vaccine uptake. We have a lot of states that have state mandates on immunization, so you can see where Washington is, where you have Tdap required for kids to enter secondary school. A lot of states also have hepatitis B requirements. But as you can see, the only place that has a mandate, this is not talking about doing vaccinations in the school, it's saying before you can enter school, middle school, you have to have proof of these vaccinations. And the only place that has done this for HPV is Washington, D.C. So now we look at the trends of what we've been seeing for the continued uptake with HPV vaccine compared to Tdap and meninge. And clearly the slope of this curve is significantly lower than what we're seeing for other adolescent vaccines, especially if you're looking for the 3 doses that we would like people to achieve. We're not even up to the 40% rate of vaccinations in girls, and obviously we've just started with boys. So we kind of are wondering what went wrong. Why aren't we doing better with our vaccine uptake? Certainly when the vaccine came out, it kind of got out quickly as a sex vaccine. And people are wondering, why are we vaccinating people at age 11 and 9? My child's not sexually active. They don't need this. There's too many vaccines out there anyway. I'm one of those vaccine hesitancy parents. I don't think I really need to have this for my child. There was also a lot of push for school mandates that got a lot of people worried that girls actually could not attain educational levels of involvement because they'd be excluded from schools if they hadn't been vaccinated. So that was very controversial. There was just communication strategy problems that we had in our country with the sex, cancer, politics, religion, things going on. It got politicized. I think we remember we had some politicians telling you HPV vaccine caused mental retardation. A colleague of ours from Australia they've done a fantastic job of HPV vaccine at a national conference said, "Do you think maybe she was vaccinated?" So, and we also have some of our pediatricians that are having trouble. So it's been a challenge. So I'm here to tell you that we have actually identified that it's not that people are not accessing care. We know girls are going in and getting meninge and Tdap. And if we took advantage of vaccinating when girls are in the office of their pediatrician, their adolescent doctor, we could get our vaccination rates up to 94%. So we basically are having huge missed opportunities in the clinical environment. If we could just change that, we could be doing really well in this country. And the problem we've also found through surveys of communications with the healthcare encounter is that the provider generally kind of says, well, it's kind of optional. They don't say like meninge and Tdap, you need this vaccine today. Parents might be a little concerned and that pushes the provider away from offering the vaccine. And there are even a lot of providers that really are not convinced yet that this is a really good vaccine and that it's really important to make a strong recommendation. So I encourage you to go to the CDC website. If you need tips about how to talk to parents about vaccinating their children, We've even got little quotes that you can use if you don't know how to script it yourself, like HPV vaccine is very important because it prevents cancer. I want your child to be protected from cancer. That's why I'm recommending your daughter or son receive the first dose of HPV vaccine today. So hopefully you will look at your practice setting and make things so that we can start doing a better job of implementation of this important vaccine. Our next problem. So we're now having a problem with divergent trends of STDs and HIV among gay, bisexual, or other men who have sex with men. This is even before PrEP, and there's some concern that once PrEP is more widely implemented, our trends may continue to be divergent. So to share with you, we at CDC, I've learned now that I'm at CDC and not at the local level, at the local level, you collect all the data and you wait for CDC to get the money to you. Well, now I'm at the end of, I get the money first, but I get the data last. So we have sort of, limited data that we collect at the national level on our cases. We have not even been collecting gender of sex partners, HIV status, pregnancy status, which we're starting to do on all of our cases of gonorrhea and chlamydia. So generally, we have to look at our rates of disease by just gender. But you can clearly see here when you have discordance between rates in women to men, it raises the question of whether or not there's a problem among MSM. And right now, we've got almost as high a rate of syphilis among men at 19, almost 20 cases per 100,000 population that we were seeing sort of back in the early HIV days. And when we stratify by the 33 areas that have been reporting gender of sex partners since 2007, you can clearly see that the rise in syphilis that we're seeing in the United States is predominantly occurring among MSM. One of my colleagues at CDC, Tom Peterman, has just done an analysis. It was an invited article. It's not yet been published. And he used this sort of interesting, it's called the modified Heffelfinger male to female ratio, and it makes some assumptions that basically, there were no MSM syphilis in 1994, and that we also have problems with denominators of how many MSM are in this country. We're getting better national estimates, but we don't have a lot of estimates at the local level. But we're using sort of the general estimate coming out of CDC that there's, in the population we've got, about 4% of men are MSM. And so this is really looking at what we think is happening with syphilis. And you can see that, syphilis was on the rise starting in the late 60s. Clearly when HIV came along, and that's sort of when I was an AIDS doctor in San Francisco as well, running the city clinic, and we had 1,000 cases of primary and secondary syphilis in this little city of 7 by 7 miles, back in 1987, 1988. There was a dramatic decline for a variety of reasons, but clearly some was related to individuals dying or people being very, very ill. And now we're starting to see this resurgence of syphilis among men who have sex with men that we're concerned about. And it seems to be occurring at a time that our rates of HIV incidence overall in gay men are on the decline, or at least they're plateauing. And so we're sort of, have some hypothesis of what's happening, but it's important for everybody to know that syphilis is back. We're also concerned because when we look at co-infection of HIV and syphilis in the 29 states that were receiving the data, I want to highlight what we're seeing in younger gay men. So already if you look at African American or black MSM in the 20 to 24-year-old age group, already 50% are co-infected with HIV. We're not yet seeing that high rates of HIV in Hispanic or white men, but this is a concerning trend of what's happening in terms of HIV transmission in this younger population. We're also concerned that we're seeing a lot of repeat syphilis. It used to be, you'd have a case of syphilis and they'd say, yeah, I had syphilis like 20 years ago, 10 years ago. Now we're seeing, and at least we have data out of San Francisco, that 30% of their primary and secondary syphilis cases in San Francisco have been reinfected within the last year. So we think we've got sort of a concentrated network and high prevalence of syphilis in MSM, especially HIV-positive MSM. People have more access to care, so they're going in and getting screened. Then they get treated. We don't think that you carry immunity after you're treated. There may be some, Sheila Lucart's been educating me, but in general, we think you're susceptible after you've been treated for syphilis, even though antibodies persist. And then these men are re-entering sort of the risk pool for syphilis and getting it again. We're also challenged by the fact that a lot of these men are having a lot of anonymous partners. And so our traditional contact tracing programs are not working because to do contact tracing, you need to know who your partners are. And syphilis is sort of a unique bacteria. First of all, it has a very long incubation period, about 3 weeks. So if you know who your partners are, we have opportunity to go out and find them and treat them before they ever become infectious. So syphilis has been the one STD that contact tracing is really, really effective. And that's how we've really eliminated syphilis in heterosexual communities where people knew their partners. But we're challenged with the number of partners in the gay community who have syphilis at the moment. There's a lot of internet use and things like that. So partner services is really not working for us. The other opportunity we could have is, syphilis is a bacteria. The only host is humans. So if we could just have a World Penicillin Day, we could eradicate syphilis. So we may be doing that soon because I'm running out of interventions for the trends that we're seeing with syphilis. So I just want to remind you, because a lot of times, syphilis is one of those things that, people sort of think, yeah, but they don't really think when the patient comes in. As a matter of fact, I just want to warn you, there's an outbreak going on in Portland right now, and we did an outbreak and a case control study, and believe it or not, a significant number of those cases were totally missed. They presented with symptomatic syphilis, were missed by primary care doctors. So, people just didn't really realize that syphilis was back. So I want to remind you a few things about syphilis. Everyone was sort of trained that chancre, that single solitary lesion. Well, actually, a lot of times syphilis presents with these very subtle multiple lesions that looks just like herpes. This is one example that you can see here. And actually, studies have shown that in HIV-infected patients, they're more likely to have multiple lesions than sort of the classic single solitary painless indurated chancre. This is another example we had at City Clinic of a resolving case of syphilitic ulcers, which was actually diagnosed as resolving herpes. It's also important to make sure that you check where sites of exposure are, because syphilis can infect pretty much anywhere on the body. It enters through micro or macro abrasions. I even have another picture of a chancre on someone's finger in the day when we didn't actually wear gloves in medicine. So it's important to do good sexual history to be able to identify these sites of infection. Again, rash is the the most common finding at the secondary stage of syphilis. Again, can be very subtle, and there's a long laundry list of differential diagnosis, pityriasis, drug reaction, all these other things that people are thinking about, and they're not thinking about syphilis. So any patient today you see, especially male patients who are having same-sex partners, you've got someone with any kind of ulcer, make sure you are thinking about syphilis. Any kind of rash, any kind of warty lesion, you need to make sure that syphilis is in your differential diagnosis. So just want to share some cases, because these were things that I was seeing when I was in California, because our DIS follow up on everything. And we're still seeing those today, now that I'm at the national level, hearing about, sort of the failure to take care of our patients. So here's a 40-year-old HIV-infected male. He sees his doctor because of a rash on his buttocks. And I don't know what happened on the first visit, but he came back a month later almost, and the rash had gotten worse. It was all over his body and his scalp. And his provider thought he had zoster, so he was treated with valcyclovir. Well, he still wasn't getting better. So he actually did independent web-based research. And he came back and told his provider, I think I have syphilis. So finally, we're now into July. An RPR was ordered. The titer was 1 to 128. No confirmatory treponema test was done. And the provider happened to report to the health department. That's pretty good. And finally, we're talking from June 5th to July 7th, symptomatic syphilis guys walking around finally gets treated with 3 shots of benzathine. You should only use 1 in early syphilis. Another story. A theology student presented to the Student Health Center, I won't say which university, but I was in California, with a reddish-crusted lesion on his penis. He was treated with fungal cream. Didn't get better, so he came back and he got dicloxacillin. Then, a few months later, as the natural history of syphilis progressed to the secondary stage, he comes in with a rash on his trunk, and he actually saw his provider who knew he was gay. And the reason why I found out about the case was the guy kind of said, yeah, I strayed a little bit, but he and his partner wanted to know, when could he have sex again after he got treated for syphilis? Do I have to wait till the whole rash is gone, or, what can I do about that? So the question is, how many missed opportunities in clinical and public health management occurred in these cases? And for the ones who just want to guess 7, no, I made it a little bit harder. There were 6. So first of all, there was absent sexual history taking. There was misdiagnosis of primary and secondary lesions. And one of the principles we use in public health is we overtreat the individual for the health of the community. So there are a lot of public health laws, and I encourage every provider, wherever I talk, you better know your public health laws so you can avoid lawsuits. But most public health laws are, if you have a suspected case of communicable disease, that could be TB or whatever, you need to empirically treat your patient. Presumptively treat. You don't wait for the lab result to come back. So right now in the United States, if you have someone who is a male with same-sex partners who comes in with any kind of ulcer, they should be treated for syphilis that day. You don't wait for the RPR to come back. And you can be held liable if they go on and infect somebody else, and you just let them go out and you've got the RPR. You thought about syphilis at least, and you got the RPR, but you didn't treat. So here we had, one, people missing primary and secondary syphilis. Second of all, they weren't empirically treating them when they thought about it on the day of the visit. And then the other challenge with syphilis is these titers are constantly changing depending on where you are in your stage of infection. So if you're screening someone for syphilis today, and it takes them 3 weeks to get back in for treatment, and their titer's 1 to 2, and you treat them 3 weeks later, their titer could have been 1 to 512 when they came back. And then you get a titer after you treat them, and it's 1 to 256, and you think, oh, this is odd. It's gone from 1 to 2 to 1 to 256. So again, syphilis is the only disease I know of where you repeat the diagnostic test on the day of treatment. You got to know what the titer is on the day you treat them because you can't figure out how to follow them. And then we always have chronic problems of providers not reporting and labs not reporting to us in public health. And syphilis is the one condition, at least with our resources today, that most health departments will follow up on all cases and at least make a good attempt to do provider patient education and partner services. We also know that we've got other challenges of other STIs among gay men. Not that we're able to, at the moment, record gender of sex partners on our case reports, but looking at prevalence studies in a network of STD clinics that we have in the United States, you can see here that prevalence of rectal gonorrhea and rectal chlamydia in HIV positive patients is well above 15%. And we also know a lot of providers that kind of think, oh yeah, I think I might screen for those STDs, but all they know is just pee in the cup. So we've really got to scale up our extragenital screening in this population. So just want to remind you, we've been making these recommendations since 2006, but we still know in most healthcare settings, our extragenital screening rates are below 20%. A lot of people say they can't get the test. It is true the NAT tests are not FDA cleared at the extragenital sites, but most labs have done validation studies so that they can be used for clinical management. And if you're having trouble with finding a lab that can do it, you can call Jeannie from the state of Washington, and you can call me at CDC, and we will help you find a lab that can do it. So clearly, we're recommending that if for patients having oral and anal sex, that you get a urine test for chlamydia and gonorrhea. If there's receptive anal intercourse, you get a rectal specimen, and if there's receptive oral sex in men. So these are recommendations in men. For women, we still kind of focus on the cervix, but we also know a lot of women are now, especially young girls, are having anal intercourse to avoid pregnancy. So some providers, even though we don't have national recommendations, are looking at a sort of a hierarchy. If a woman's not having vaginal sex but's having anal sex, if she's having vaginal sex, get the cervical specimen or the vaginal specimen. If she's having anal sex and not vaginal sex, get the rectal specimen. If she's only having oral sex, then get the oral specimen. The other concerning trends that we're seeing with our HIV data are and these are things that are being done by health departments. We haven't had big research grants to do this, where we've been looking at people that present with either primary or secondary syphilis or rectal gonorrhea chlamydia. And then we can actually do a cohort study by following them through our surveillance systems to see if they become HIV positive. So these studies have predominantly been done in New York City and in San Francisco. We're trying to look at them in other parts of the country. But overall, we're looking at sort of annual incidence of primary and secondary syphilis in the New York City study of 5.6%. And for rectal gonorrhea of 6.7%. And when you actually stratify in that study by age, the seroconversion rate in the population less than 20 was 10%. And if you were African American, it was 15%. So I think the field of HIV for years only looked at biological risk factors. And so when CDC was starting to come up with their PrEP guidelines, they were just looking at risk factor screening. And we really need to be looking at biological risk screening as well. So STDs matter because at a minimum, they're huge risk factors for who, if they're HIV negative today, who's going to become HIV positive, and they are strong candidates for the new PrEP recommendations. Also, we've had some good work from Matt Golden here in Seattle that I'd like to share with others around the country. We also know, besides the fact that STDs are the most consistent risk factor for seroconversion among HIV-negative men, they're also the most consistent risk factor for testing HIV positive for people that present with STDs. So in the state of Washington, if the case presents with syphilis and they are not known to be HIV positive, if you test them at that time, you're going to get a positivity rate of 10%. For gonorrhea, it's 5%, and for chlamydia, it's about 3.4%. The challenge, again, we have, and this is hard to believe, and this is not just in Seattle, we've looked at this in STD clinics around the country. I mean, if you're in an STD clinic, you should know you should be testing for STDs. And we are only finding about 55 to 60% of people presenting with an STD are getting tested for HIV. And that's now one, Dr. Frieden's upset about that. So we now have that as a national benchmark that we're measuring. And actually Kaiser in the mid-Atlantic is doing as well as STD clinics. And so it's sort of making the argument why people think STD clinics should close and we should be sending all our patients to federally qualified health centers or the private sector. So I think it's really important to understand the intersection between STDs and HIV. And I think in a sexual health model, we've got to start having our clinical services together. Certainly I feel like STD clinics are going to have to be sites where HIV prevention interventions, including PrEP, are available to the patients that are seen. We're sort of the gateway of sort of where HIV prevention needs to happen. So the challenge we've got with these sort of divergent epidemics that are occurring in the country is that we've made great advances on HIV prevention strategies. It isn't anymore just abstinence and condoms for HIV. There's PrEP, there's seroadaptive behaviors, there's circumcision that's not on my list. And even reproductive health is doing better with their long-acting contraception. They've got some new options for women. Where are we in STDs? We're still kind of stuck with condoms. We're hoping that we can come up with a super-duper condom that's sort of like taking meth that everybody wants to do. So I'm talking to the condom companies. Abstinence, which is, good for part of your life. Reducing partners. So we're really challenged with sort of this new epidemic. And so that's why I say either we need to have a World Penicillin Day or we really need a vaccine for syphilis. And actually, Sheila Lucart's been doing some phenomenal work, and I encourage her to continue because I think there's the possibility. But so if anyone has any other suggestions for us at the CDC level of how we can reverse these trends, I am open to suggestions. So to sort of summarize how I see the role of the healthcare provider, again, providing this more holistic sexual health work. First of all, when you're dealing with STDs, you're dealing with vulnerable, stigmatized populations in general. Most people, are usually embarrassed even for the little STDs. They don't want to go to their primary care provider. They don't feel it's a welcoming environment. Their provider doesn't want to talk about it. And they want to take care of themselves. So I think it's important for people to have welcoming environments for adolescents, for gay men, for transgender people, so that when they walk in, they see literature, they see brochures, they say, hey, this tells me that this provider, is at least, saying something about serving diverse populations, and certainly it's something we expect our STD clinics to be doing. We need to do routine sexual history taking, and we can't be making assumptions. Like, I would, ask all of you, the last time you went to your doctor, did they do a sexual history taking? How many people had a sexual history? People make assumptions all the time. Oh, they're older, they're married, no, not sexually active. It needs to be routinized. It's something that's part of the work that we do. Certainly, we got to scale up our screening recommendations for all STIs, including HIV. And I think we also recognize that STDs is almost like a social determinant of health. They're really a marker of populations that are at risk of a lot of things. We probably should be doing blood pressure screening in our STD clinics and other things. But at a minimum, we're now looking at other kinds of screens. There's simple screens out there for alcohol, drug use, tobacco, depression, and intimate partner violence. So that really needs to be integrated into the work that we do. Certainly, let's not forget our vaccinations, especially HPV, but we certainly haven't completed our work on HBV vaccination, which has been around for a long time, and we still have people that have not received hepatitis B vaccination, and we still have acute infection in this country, interestingly, mostly over the age of 25. We pretty much eradicated hepatitis B in younger people because of early vaccination recommendation programs. So it's the aging cohort that's getting acute hep B infection. And again, we still need to continue our prevention messages, and one size doesn't fit all. There are going to be some people that condoms are just not an option. It's not the lifestyle that someone's looking for. We've got to look at other prevention messages there. It may be that we just have to screen for syphilis every 3 months. as a strategy in some populations. We do recommend if you have chlamydia or gonorrhea or trick in HIV-infected individuals that you should retest at 3 months after treatment. It's really because we know people tend to get infected because not all partners get treated, or maybe they go on and find another partner in their sexual network where there's high prevalence of infection, so they get reinfected. Beware of antimicrobial resistant gonorrhea. So if you've got a possible treatment, reinfection, which, I think we always thought repeat infection is all reinfection, step back and think, maybe could this be that superbug that's come to the United States, and try to find a culture and get antimicrobial susceptibility. And lastly, syphilis is not going away, so please don't give me any more case reports that I can present on missed opportunities. And again, there's a lot of resources out there. Jeannie's in charge of your training center. We do put out treatment guidelines at CDC. Again, when I started in the field back in '87, I was like, why does CDC have treatment guidelines? They're like a prevention agency. This should be the AMA should put out treatment guidelines, or IDSA. But then I quickly learned that many providers, both in medical, even in nursing school and medical schools, don't get adequate training. So these are a rigorous, authoritative, evidence-based source. We've got a mobile app. So we encourage you to download the app because we know everyone's busy. And even what we found since this app has been out there, we actually have a condition quick pick, and we have the full treatment guidelines, the 100-page document. Nobody picks that. So to be honest with you, it's quite expensive to load that onto our app, so we're actually thinking of taking that off the app next time and just leave these quick picks where you go to your condition, and it tells you what drugs to use. And then for those who really want to be informed, you can go to our CDC website and look at the full document. So with that, I want to stop and have time for some questions, and I really appreciate your attention this morning. You can ask me anything about STDs. It doesn't have to be about our threats. We'll go back and then, is there a microphone? Okay.
The Australians started providing the HPV vaccine in the schools, I think in around 2010. And so their entire population, male and female, is getting vaccinated. Do they have data yet on cancer rates?
Yeah, and we've got Judy here, who's also very involved in the international world of HPV. But yes, they've got very good data showing reduction in warts and cancer and precancerous lesion and other things.
Because it seems like advertising that data, saying this is a cancer vaccine, look what the Australians have done.
Yeah, Uganda's done even better than we've done in the United States. So we're trying. I think the strategy is we're trying to. The cancer part is the easy sell, and we're also trying to get OBGYNs who have taken care of patients with cervical cancers, educating pediatricians who really have never seen the ravages of the disease to see if that can also help build the bridges. We have more to do. And there's actually some epidemiologic data that oral cancers are associated with oral sex. And I think that this vaccine is also going to have huge benefit at other sites as well.
Actually, anecdotally, in many Australian STD clinics, they're having trouble finding enough warts.
Yeah.
That was great training.
Yeah. Judy.
Gail, that was terrific. Thank you. I want to talk about syphilis. The rates you showed us in men who have sex with men are now comparable to the peak of the last syphilis epidemic.
Yes.
In 1990, when the rates hit 20 per 100,000, alarms went off, CDC went into high gear. We really tackled this. At the same time, we're now moving into an era in which PrEP is quite appropriately going to be scaled up. One could postulate that the epidemic we're now seeing in MSM for syphilis will go even higher, off the charts. So the question is, what's CDC doing about that, and what should we all be doing about that?
Okay, so first of all, the epidemic that Judy described in 1990, for those of you who didn't know it was happening or were not around, was a very different epidemic. It was an epidemic among heterosexuals. It was among underserved populations that didn't have access to health care. It was related to crack cocaine. And once we scaled up culturally competent clinical services, scaled up our public health efforts of contact tracing, got communities involved, got communities seeing crack isn't the economic answer for black men not having jobs. It actually, when they started selling crack to their community and pregnant women were starting to have congenital syphilis babies, the communities decided to take crack and get it out of the community. So we got syphilis down to Seattle got down to no syphilis cases. So now we've got a problem. It's a different epidemic. It's in a different population. And what CDC is doing is we are, one, getting better data out. Two, we need to do better science to understand the root causes of what's happening and how is it being impacted by HIV prevention successes and what are the unintended consequences that are happening. We're certainly educating providers. We're educating the gay community. And I would say that, I think PrEP is a harm reduction strategy. It's not going to be take PrEP and don't use condoms. I think there's still going to be encouragement to use condoms, but we haven't even started PrEP yet, and obviously the interest in condom use among some individuals is not a priority. I mean, if you already have HIV, we now know it's, there's medications, it's a chronic infection. People want to be sexually active, and for intimacy reasons, there are just, condoms have just been not attractive to everyone. So I think we've got some challenges ahead. I think we've got to get the data to see where we are now and where are we going. Certainly we at CDC, I don't have a robust research budget, but we're trying to work with HIV intervention, cohort studies, and PrEP trials so we can actually add on STD testing and look at what the consequences are and what the factors that are associated with it and what are the interventions that we need to design. So yeah, it's a problem. Hunter, you got an answer?
Just to take it to one specific step, the rates of syphilis in King County in MSM are in the range of, if you estimate roughly how many MSM there are among male populations, 1% per year among MSM in general, and 3 to 5% of all HIV-infected MSM are acquiring syphilis every year. There are few, if any, populations in the world ever, defined populations with rates of syphilis that high. So those of you providing primary care, the messages are take that sexual history, do the screening, and particularly in HIV-infected MSM, you can make an argument that if you're providing care to such men that you should be doing a syphilis serology maybe at every clinical visit, maybe every single time they come in. At least take a history and consider a screening.
Yep. Do you have your outside viewers beam in at all, or that doesn't work here? I didn't know how, I've done a lot of, Kaiser has systems in California, you beam to everybody, and they have ways you can have the outside sites ask questions.
No, they can't ask questions,
Oh.
but with the microphone they can hear the question.
Okay.
Gail, so I have a question, a comment and a question. Thank you so much for that. So the comment is just to make sure people caught that incidence of HIV in men who have a recent diagnosis of primary syphilis in New York City. If you're a young man with a recent diagnosis of primary syphilis, the HIV incidence in the subsequent year is 5%. If you're a young black man, it's 15%. That's higher than most places in sub-Saharan Africa.
Yeah.
I mean, if you look at HIV incidence in young women outside of Durban, maybe you'll get to 10%. But this is unbelievable. So I hope that.
And don't forget the rectal site. It's just
Yeah.
bad. And and most people don't know about it because they're not screening for gonorrhea in the rectum.
So that's one thing. And then I wondered if you could just comment on the outbreak of congenital syphilis that's happening now, because I think that really is, talk about a public health failure and challenge.
Yeah. Yes, and syphilis is hard to transmit, as I said, because it's not only long incubation periods. You only have the lesion for a week or two, and So I did make congenital syphilis one of my priorities at CDC because it was one of our global priorities at CDC. And I say, why do we always leave the United States out of our global, priorities? And I thought it was low-hanging fruit because we've done so well with congenital syphilis and heterosexual transmission. And I'm now, and when we haven't got the data, this is all very preliminary, but we're now hearing outbreaks of congenital syphilis occurring in this country. I'm sad to hear that it's occurring in California. It sounds like it's in the valley. It sounds like it's related to meth. We're also hearing that fairly wealthy Chinese women are coming to California to deliver their babies so that their babies can be citizens. And I thought demographically, wealthy Chinese people coming in and having babies with congenital syphilis, but it seems to be people are wealthy through the sex trade. So this is another, we do see a lot of congenital syphilis in adopted kids in this country. So I would say, again, to me, congenital syphilis is a sentinel event. It is a failure of the healthcare system, and it's a failure of your health department. And I bet you if you've got congenital syphilis, you've got mother-to-child transmission of HIV and probably a lot of other problems in vulnerable populations. So remember, If you're worried about congenital syphilis and you've got high rates of disease or high-risk people, you screen 3 times during pregnancy. Don't assume your patient is low risk. And if someone has no prenatal care, that woman should not leave the hospital until she knows her pregnancy status. Her syphilis status, her RPR status. You can get an RPR in 20 minutes. I don't know anyone who delivers a baby and leaves the hospital in 20 minutes. And usually they're worried about the baby, and a lot of these women are drug-using moms. They leave quickly. So we really can't let women who have no prenatal care leave until we know their syphilis status.
One more question?
Oh. Could you comment on starting age for HPV vaccine?
Starting age.
Yeah.
So basically you can go down to 9.
What's the rationale for 9 as opposed
There's
to
some
young?
limited immunobridging studies is basically the rationale that is going down to that age. The routine for everybody is 11, but there's permissive language to go down to 9 in both girls and boys.
I mean, it just does strike me that there's just like the whole flurry of like preschool vaccinations and everything is kind of, this is the routine, this is what everybody does. Yeah. And then people get to sort of 9, 10, 11, 12, and they're not going to the doctor as often. It's the complicated regimen that you have to come back and back and back. Yeah. So why not sort of start it? Is there a good?
Well, no, there's some people that say we should put it into the newborn package. Yeah, no. And then there's the whole controversy of the 2-dose, because the WHO has now recommended 2 doses for younger people because they get much higher immune response. The younger girls get a higher immune response than older.
Population data even suggests that 1 dose is
Yeah.
better than none. And so even if you don't think you're going to have an opportunity to get the second or third dose in, at least give the first, then opportunistically hit them up whenever you see them, no matter when it is.
Yeah. And it was the same argument yes. It looks very good, but ACI, I have to say what the ACIP is recommending. But it was the same issue with Hep B. We used to have people in STD clinics say, well, we can't give Hep B vaccination because no one comes back. I said, if you can get 1 dose into a high-risk population, you're getting 60% immunity. You're going to be doing well for, a population approach. So I'm always a believer, just do as much as you can when the opportune time comes, and hopefully we'll make some progress.
Thank you very much.